Welcome all of you from across the world to Hernia University, Hernia U, where we have today Dr. Sebastian Schoppmann and Dr. Steve DeMeester, both of them with the heritage of having trained at USC under the tutelage of Dr. Tom DeMeester. Professor Schoppmann has been in Vienna and has done extensive research in Barrett's esophagus along with anti-reflux surgery. He's the chair of the Department of General Surgery at the Comprehensive Cancer Center at Department of Surgery, Medical University of Virginia. He's also the head of the Esophageal Function Laboratory, president of the Austrian Society of Surgical Oncology, multiple publications, over 200 to his name. And he's the founding member of the European Foregut Society. And Sebastian, maybe at some point, towards the end, we'll talk about the American Foregut Society and the European Foregut Society. Steve DeMeester, to many of you, needs absolutely no introduction. But currently, he is in practice at the Oregon Clinic, which is really probably currently the premier foregut training institute in the U.S. They've turned out fantastic fellows that are going across the U.S. and across the world doing foregut surgery. Beyond that, he's got over 190 peer-reviewed publications. He's been the chair of an ongoing 30-plus year meeting that Tom DeMeester and Don Castell set up originally in Hawaii, talking about esophageal disorders. Anyway, both of them are fantastic speakers and are going to talk to us today about the hiatus, about how to get adequate esophageal length, when to do a Collis procedure, and they're also going to talk to us about how to close the hiatus well. I'm going to start out with just a poll question. I think you have a poll on the lower right hand of your screen. And the answers refer to Steve DeMeester or to Sebastian Schoppmann. But I'm going to ask you, if you are from the US, to respond that you agree with Steve DeMeester. Doesn't mean you have to agree with him, but just that's where you are. And if you are from outside the US, respond that you agree with Sebastian Schoppmann. And that'll give us all an idea of how many of you are from the US and how many of you are from outside the US. And while you're responding to that, I'm going to turn the controls over to Dr. DeMeester, who's going to give us the argument for Collis gastroplasties. So Dr. DeMeester, take it away.
Thanks, Reg, and look forward to this time with all of you and a friendly debate format with Sebastian, and we'll look forward to back and forth a little bit. Look forward to your questions, comments, and chime in, because we had sort of talked about this, setting the debate up. There'd be no point to debate if we knew all the answers. So this is uncharted in a way that we don't have scientific proof on one side or the other. We have opinions, we have our own data and our own surgical sort of knowledge of the patients that we've operated on and followed over the years, but none of this is written in stone. So we're trying to sort our way through this, and I think the exchange is beneficial for all of us to help hear different concepts and thought processes as we move forward in this challenging area of paraesophageal hernias. So I'm going to hopefully share my screen with everybody. Let's see if this comes up properly. There we go. So we'll be talking about some of these controversial areas in paraesophageal hernia repair. Bard is putting this on for everybody, and it's certainly a nice opportunity for educational event in this COVID era where it's hard for meetings to happen and for us to interact together. So fortunately, we have a virtual platform where we can share ideas and discuss and hopefully grow in our experience and our thought processes. So I'm going to start off the topic here about the short esophagus and even take a step back and a couple concepts about tension. Tension is the enemy of any hernia repair. We've known that as surgeons for decades. And since paraesophageal hernias are a type of hernia, then tension can't be good for a paraesophageal hernia repair either. When I think about it, I think there are two areas or types of tension related to paraesophageal hernia repairs. One is axial tension, related to perhaps loss of esophageal length or short esophagus, and the second is lateral tension, related to large hiatal defects and trying to reapproximate and reshape the hiatus. And perhaps long-term paraesophageal hernia repairs depend in part upon addressing tension. We know from 2 randomized prospective trials that recurrence rates are high, upwards of 50% at 5 years after paraesophageal hernia repairs. So we do have an issue in terms of recurrence. Perhaps tension plays a role in that. But if we're going to think about tension, it's important we at first be able to recognize when tension is present. If we don't recognize tension, we're not going to be able to address it. So when we think about the short esophagus, couple issues. First, how much intra-abdominal length of the esophagus is necessary? How do you measure intra-abdominal esophageal length? What factors might affect your length measurement? And then if we decide in an operation the esophagus is short, what are our options? So issues, how much intra-abdominal length of the esophagus is necessary? Well, most people believe, first of all, that you have to put a fundoplication above the gastroesophageal junction. If you put it below the gastroesophageal junction, well, that's of course a slipped fundoplication and creates the 2-compartment stomach and is not a functioning repair. So the fundoplication needs to be above the GE junction. Typically, we believe that a fundoplication takes about 2 centimeters or so of space, which would then mean you need about 2.5 or up to 3 centimeters of intra-abdominal esophagus, where you can put that fundoplication above the GE junction and not have tension on the repair. So the next question is, all right, if we need this 2 to 3 centimeters, where do you measure it from? And there's lots of different concepts about where to measure it from. My opinion is that since recurrences happen on the left side between 12 and 3 o'clock, that's where that fundus slips back up in most recurrent situations. To me, that's where the length needs to be. So I think that we need to measure from the left crus to the GE junction or the angle of His and be looking for that 2 to 3 centimeters from the left crus to the angle of His. But in order to determine that, you have to know where the GE junction, the angle of His is, which means you need to really clean off that posterior portion of the hernia sac to well define the angle of His. And sometimes the angle of His is so splayed out, it's hard to tell. Then you might need to do an intraoperative endoscopy to definitively determine the true gastroesophageal junction. But once you know where the GE junction is, then you can determine your intra-abdominal length by measuring from the left crus. So in this example here we see a cleaned off angle of His and GE junction. And if we look at this, let me see if my pen works here. Yeah, so this is sort of a splayed out angle of His, and probably right in about here is our GE junction. We could put a scope down and confirm that, but let's assume that's the GE junction. Now, if so, then here's our left crus. There's our angle of His. And this is the distance that should be 2 to 3 centimeters. Well, this is nowhere near 2 to 3 centimeters. That's at best 0.5 or 1 centimeter. So I would consider this to be a short esophagus. Now, what factors affect length measurement? First, recognize many of these patients with paraesophageal hernias are kyphotic. And in a kyphotic patient, when we close the hiatus from posterior to anterior, we bring the esophagus anteriorly and actually gain length. Compared to where the esophagus was posteriorly here, and you just barely have any intra-abdominal esophagus, by closing the hiatus posteriorly, we've gained quite a bit of intra-abdominal length. So number one concept is close the hiatus posteriorly at least a bit before you assess your length intra-abdominally. Second issue, the position of the diaphragm related to the capnoperineum, I think, can lead to overestimation of esophageal length. When you've got the abdomen full of gas, it has pushed the diaphragm way up into the chest, and that over exaggerates the intra-abdominal length of the esophagus. Once you let that gas out, diaphragm comes back to a neutral position, all that intra-abdominal length of esophagus suddenly disappears. Now you can get around that intraoperatively during your laparoscopic surgery by simply making a pneumothorax. Open the pleural space, let that air equilibrate, and it brings the diaphragm to a neutral position and gets rid of that false estimation of esophageal length. Lastly, any traction on the esophagus completely alters your assessment of the true length of the esophagus. This video clip illustrates that. It looks like we have beautiful length until we let go. And this is not much tension, just barely pulling on it. Look, we can have 4 or 5 centimeters intra-abdominal length, but the minute we let go, it's gone. And I don't think that pulling on that GE junction and doing your funduplication is going to lead to a successful repair. That repair is going to try to slinky back up in the chest, just like you saw in that video clip. So here's a patient that has normal esophageal length. It does exist. This patient, here's our left crus, angle of His way down here. We have a good 3 to 4 centimeters in this patient. So the true length of the esophagus does exist. It unfortunately is not very common in my experience in patients with paraesophageal hernias. So if we have a short esophagus, maybe we only got 1 centimeter of intra-abdominal esophagus, not the 3 we're looking for, what are our options? Additional mobilization, vagotomy has been described, the Hill procedure where you crank it down and anchor it to the median arcuate ligament, or a Collis gastroplasty. My preference is the Collis gastroplasty. 48 French or 52 French bougie goes down along the lesser curvature. First angle of the stapler goes towards the angle of His. You're not trying to take out very much fundus. Subsequent staples head towards your mark 2 or 3 centimeters down along the esophagus. Get up flush against the bougie. Once you're flush against the bougie, you head north and take out that little segment, and you end up then with your completed intra-abdominal extension, 3 centimeters of esophagus, and now you can take that funduplication either as a Nissen or as a toupee and completely cover the staple lines, which leads to a very nice repair and very low risk of a leak. In fact, in my experience, it's one of the few things in surgery I've not had a leak from, and that's a primary laparoscopic Collis wedge fundectomy. I've had 0 leaks with that approach. So the final issue is, does it make any difference? So we are following 50 patients prospectively as part of an initial study for the Phasix ST mesh. We have mean follow-up now over 31 months. And interestingly, in these patients, there's been no recurrence in a patient with a Collis gastroplasty. Among 44 patients with at least 2 years of objective follow-up, 21 had a Collis and 23 didn't. Significantly fewer recurrences in the patients that had a Collis, because there was 0 in the Collis group versus 5 in the group without a Collis. So it's interesting. You would think if you had a short esophagus and you did a Collis and the Collis isn't helping, we should have at least as many, if not more, recurrences, and that's not been the case. Sebastian, I'll turn the screen over to you at this point.
Hello, everybody. Happy to be with you. Happy to have the big honor to have a discussion with Steve Labayer. And let me go directly into my thoughts about the short esophagus. I'll try to share my screen right away. Here we go. There it is. Here we are. So, Steve, this is my thoughts about the short esophagus, and I'm sure I've not seen that many as you. I completely agree that it is absolutely essential to have the intra-abdominal esophagus in the abdomen if you go for any kind of anti-reflux procedure. And I absolutely agree that it's not very easy to measure the 2 to 3 centimeters that we both think we need for this. I don't completely agree what you said that it is absolutely necessary, because if you go through those publications, you will see that you can, even with things like this, like stomach around stomach fundoplication, you can even get quite good outcome that are comparable with the outcome you have with Collis Nissen. And the second one is we know that even patients who have reherniation after fundoplication links, many of them are quite good concerning their symptom release. I absolutely agree that if you go for surgery with the esophagus and if you mobilize the esophagus, you will see that there's long and there's short esophagi. And again, I agree that our goal when we go for this kind of surgery should be that we have to achieve an esophagus that is around 2 to 3 centimeters. However, we measure that and comes into the abdomen. I think if you do a standard esophageal mobilization, which means you go up to 5 to 8 centimeters into the mediastinum, you will get this length in around 90% of patients. And if you do a more extended one, and some surgeons would call it like type 2 esophageal mobilization, you will get another 8%, which means you go up 8 to 16 centimeters up into the mediastinum and you will mobilize the esophagus. So therefore, I think there's 3 good things with the short esophagus. The first one is, I think it's only around 1 to 2% of patients who really stay with an esophagus after mobilization that cannot really be abdominalized correctly, which means that cannot be reduced to the 2 to 2.5 centimeters after optimal esophageal mobilization into the abdomen. The second thing is, I think we will see less and less shorter esophagy within the next years, because one of the things we believe is responsible for the shortening of an esophagus is like a peptic stricture. And we know that those stricture rates really decrease within the last years. So this is a very recent publication showing that like 30 years, 40 years ago, there were strictures observed during anti-reflux surgery from around 17%, and the most recent cohort from the same surgical team was like 1%. So I would expect that we might even see less and less shortened esophagy in the future. And this is, I think, very, very important. This is a recent publication showing big centers defining their kind of short esophagi and putting it in correlation to the clinical outcome. And you see there's no correlation at all, which means you have centers that have like, they would define or they would diagnose short esophagi in up to 30% of patients having the same clinical outcome as centers that define 0 patients with short esophagus. All of them have never done any lengthening procedure like Collis. All of them have been standardized or extended mobilized. So even if we talk about the 2% of patients who maybe need a Collis Nissen, I think there's some things we should know. And this is the things why I almost never do a Collis Nissen. This is, you will reach an increased complication rate. This is recently published data, just comparable. All of them were patients who had shorter esophagi, and you'll see the complication rates are around double as much as for regular Nissen fundoplication. And you will learn that you will have different complications, like you will have splitting of suture and you will have gastroplasty fistula, which is something quite new when you start with Collis gastroplasty compared to a mobilizing or extended mobilization. And what we know is that around 30 to 50 patients after Collis Nissen gastroplasty will have abnormal, quite high distal esophageal acid exposure. You can measure this. We think for sure it comes from the acid production itself, from this so-called neoesophagus, and we also think that it might be due to reduced clearance function of the neoesophagus, which is stomach. At the end, it might even be added by some rigidity of the staple lines at the end. Third point would be that in big cohorts, you see that up to 15% of patients after Collis Nissen have dysphagia in the long term. again, due to the motility and maybe to the high pressure zone, and maybe in long term also to the pectic stenosis you really see in patients after this. Another quite interesting recent publication shows in patients that all had, for their experience, short esophagi, and these were two groups. The one group had a Collis Nissen found on the left side, and the right group was patients that had a short esophagus and would have needed a Collis Nissen in their perspective, but they were not fit for Collis. So what they did again was this stomach around the stomach fundoplication, which just means that you wrap the stomach around the stomach, which is at the end the same anti-reflux procedure you do after Collis. And you see that their results were almost the same. They were exactly the same. Yeah, so this is my answer, Steve. And some questions to challenge you.
I think we get a chance to rebut a sec. So if you can stop screen sharing, or maybe I can take over a second. I get a minute to just rebut you, and then you get a chance to come back at me again. So let me get to a blank slide here. So I agree with you a lot of things. I think it is, it's in the eye of the beholder how commonly you see a short esophagus. You will recognize that it does exist. And over time, as I got comfortable with the Collis, no doubt I'm making more and more, because particularly a very short Collis is so easy and quick to do. And there's a lot of technical issues which are important. And the first issue in terms of this, so if you have only, if you have 2 centimeters intra-abdominal esophagus and you need only a 1 centimeter Collis, I mean, that is just the simplest thing in the world and gives you that nice little extension. In terms of the esophagitis issue, that is an issue. In our experience, esophagitis has been about 10%. And dysphagia is no different than compared to a straightforward Nissen. But the important thing with a Collis is this neoesophagus is aperistaltic. So you actually want it to funnel down. That's why I don't think a wrap around the stomach is the same. You want a smaller bougie. This should be 60 French. And the biggest I'll use is 52, usually 48 to 52. You want this to funnel down because it's aperistaltic, and that's how you minimize dysphagia. The second important thing is to keep your fundoplication at the top of the Collis, if at all possible. That way you don't have any of that neoesophagus acid production getting into the esophagus. In patients where the esophagus is very, very short, and in fact you end up with the Collis going across the diaphragm, you have to keep your fundoplication below the diaphragm, which means they're going to have a little neoesophagus making acid. Those are the patients that will need to go on some acid suppressing medication for esophagitis, but that's the really short esophagus, and it's not very common. Okay, well, those are my comments about that.
Sebastian, thoughts that you have?
Well, no, I'm thankful for those technical aspects. I understand them. I'm not sure if they really convince me that you can avoid this neoesophagus really producing acid that runs up into the esophagus, which is not blocked anymore with an anti-reflux functional LES. So I'm not sure if you can convince me that this small technical detail would avoid that. Well, what about the complications, Steve? Oh, he's having a chat.
No, I'm good. So in terms of complications, it's really related. In the old days of Collises, when we did it for severe reflux disease, no doubt. Complications, big time, because they had strictures, terrible reflux. Patients with paraesophageal hernias typically don't have bad reflux. They don't have strictures. They don't have esophagitis. The esophageal tissue is healthy, and we've seen very, very, in fact, I've seen no leaks, no issues in a primary. Now in a redo, yes, I've had 2 patients in redos with a Collis where the esophagus was very scarred, and we had 2 small leaks that healed with pigtail, internal bilateral pigtail drains that we put in endoscopically. But those are the only 2 leaks I've had in my whole career with the laparoscopic wedge fundectomy approach. It's really very, very safe if you follow the technique.
Okay, well, great conversation. Clearly an unresolved issue between someone who does nearly 50% collises and someone who does 1.5% collises. So, but let's move on now to the next stage of the debate, and that is repairing the hiatus once you've got enough esophageal length. Do you use mesh or not? If you do, how do you use it? And do you do relaxing incisions? So, Professor Schoppmann, take it away.
Okay. Well, just 2 slides concerning the hiatus. Let me see how I can share it again here. Here we are. Okay, here we are. Well, I think, again, and Steve has told us that during his introduction, I think it's very important that not only herniation itself is multifactorial. And today we know that there is some mechanical stress factors. That was what Steve told us when we started this interesting debate. And there are cellular, and today we even know that there is genetic factors influencing the risk of herniation and the risk of herniation. So I think there's going to be a lot of different things and a lot of other ways to fight against reherniation in the future. When we talk about mesh today, the evidence, I think, is quite easy to bring together. We believe that short-term mesh placement might help. And we've seen it in quite a couple of studies showing their 6 months results that the number of recurrences really is smaller than the number where just suture was done. But in long term, and it doesn't really depend what kind of mesh you implant, and it doesn't matter what kind of shape of mesh you implant. In long term, there is no real difference between mesh or just suture concerning the recurrence rates. And we still have quite a lot of concerns about long-term side effects implanting, especially long non-absorbable meshes, in sometimes ending up in esophageal. But I think we might have been a little unsensible concerning judging the results of mesh, because I think even though I agree with you that most of the reherniations or most of the herniations appear on the left side between 12 and like 7 o'clock or 5 o'clock, I think we really have to differentiate between 3 kinds of recurrences after herniation. And what we very often see is the anterior one, which has not really anything to do with the repaired hiatus from the beginning on. And what we judge on the studies that we take for evidence when we talk about meshes is just the meshes that had been implanted to secure the posterior hiatal defect. So maybe we're a little unfair judging the effect of meshes. And the second one is, I think time plays a very important role concerning the hiatal hernia recurrences, because we see that it is really time depending where and to what time point the hiatal hernia recurrence appears. And we see that especially the posterior recurrences appear quite early, with a median around 1 or 1.5 years. So maybe this can really be an interesting point to still think about an important role of meshes in the future. So this is my ideas concerning mesh. Steve?
Okay. All right, so I'm going to just talk briefly about my concepts of crural tension and mesh. So there's no doubt there's some degree of tension anytime we close the hiatus, particularly in these paraesophageal hernias. We have these massive defects, and you got to restore that to something the size of the esophagus. And I'm also going to assert that our visible and haptic feedback with laparoscopic instruments, even worse probably with robotic instruments, is flawed. And if you think about recurrences and the repair of the hiatus, you know, should be sort of like a V shape. And then when we repair it, we close the hiatus down and we put our posterior stitches. Well, if a stitch is going to tear out, which is the one with the most tension? Not this one, not this one. This is the one with the most tension. If that one tears out and this opens up, it's no doubt we get these slips of fundus coming up exactly where we see them. So I think recurrences are related to that uppermost stitch tearing out because of tension. And a torn suture, I'm going to advocate, in most cases leads to a recurrent hernia because you have a vacuum in the chest and a positive pressure in the abdomen, and it's going to suck that fundus right back up in the chest. And this is some data that we've been working with. We do tensometer objective measurements of closure tension in all of our paraesophageal hernia repairs now. And we're looking at our subjective sense of tension versus measured tension. So on the side here is measured tension. This is our subjective tension, with yellow being mild, and the purple will focus on those being what we perceived as high tension. When you start getting about 4 foot-pounds of tension, we're getting into the relatively rare group where there probably is high tension. So I like to see my tension more around 2 foot-pounds or so. Sometimes at low tension, we interpreted it as high. Other times at high tension, we interpreted it as low. So our subjective sense isn't that great. Now, there's a lot of issues with crural closure. The types of sutures, whether you use running, whether you use interrupted, whether you use pledgets. Important issue, how tight to make the hiatus. I think people are scared to over tighten the hiatus. They leave it too loose, and you've got the makings of a recurrence before you've even deflated the abdomen. Anterior versus posterior sutures and the deformed hiatus, the big D-shaped hiatus. Some people talk about reefing up that left cruce. Is that the right way to do it? How do we manage the deformed hiatus? Tension reducing techniques when we have a huge hiatus and we're struggling to get it together, and then the mesh reinforcement. So this short video clip shows you my technique. I like pledgeted sutures. I've done over my career simple sutures, figure of 8 sutures, all kinds of things. I really think that there's nothing that provides the secure closure like a horizontal mattress pledgeted suture. So in a second, these are O-ethibond sutures. They're spaced about 8 millimeters apart, and the pledgets I use are absorbable. I used to use permanent pledgets and dug those out. So there's a Phasix ST pledget. Bring the other side in. We use the tie knot device, which is how we measure the tension, and that secures the hiatus. Sometimes we'll put an additional unpledgeted suture or a figure of 8 like we did here, and notice how tight the hiatus is. There is no room between the esophagus and the hiatal closure or the crural closure. I don't want to be able to see any gap there. You can always dilate that up a little bit with a dilator if you need to, but I think we underclose the hiatus more than we overclose it. So I like this pledgeted closure. You get a nice stout crural closure, nice tight closure around the hiatus. Sometimes you need some anterior stitches to reconstruct the hiatus, and we'll talk about that in a minute. Is there evidence that we can reduce crural closure tension when we encounter it? Yes, there is. I encourage you to read this paper by Daniel DeVillo Bradley out of Swedish with Ralph A. and company, and they actually put in a tensometer and measured the crural closure tension, showed that by making a pneumothorax, they dropped the crural closure tension by 36%. A right-sided relaxing incision dropped the tension by 46%. Do both together to maximize an almost 60% reduction in crural closure tension. So there is a way to reduce the tension when we encounter it. Right-sided relaxing incision is the most common one that we use. We simply make a long muscle along the vena cava here of the cruce of the diaphragm. This allows you to reconstruct the reconstructed hiatus. And then this is the defect that is left behind, which is then repaired permanent patch. We're in the process. We had an ISD presentation accepted, but the ISD meeting has been canceled. We're in the process of publishing the manuscript. 70 patients with diaphragm relaxing incisions. As you can see, the majority on the right, some left, some bilateral, all repaired with permanent Gore-Tex mesh. One single patient, 2%, had a hernia through a right relaxing incision when a couple of the sutures along the vena cava tore out 9 months post-op. This did require urgent surgical repair. It's the only patient that's had a hernia through the relaxing incisions. In that patient, the hiatal repair was perfect. It was fine. It was a hernia through the defect on the right side that stitch had torn out. We've had no mesh or symptoms attributable to the relaxing incision or evidence of a paralyzed diaphragm in these patients. And on follow-up objectively now at a median of a year in the patients, 11% paraesophageal hernia recurrence rate in patients that had these huge, nearly unreconstructible hiatuses before the relaxing incision. So I think it makes sense. Now, what about mesh? Why does mesh make sense to me? There's no fascia on the crura. They're like filet mignon. It does not hold sutures. These patients are elderly, and as Sebastian said, they oftentimes have collagen defects and other hernias that have been repaired or are present, ventral hernias, inguinal hernias, and so forth. These are hernia-prone patients with collagen defects. Many of them are kyphotic. The curvature of the spine, the kyphosis, alters the tension dynamics at the hiatus. So when we go in to do a paraesophageal hernia repair, we're not making them young, we're not making their tissues strong, we're not fixing their collagen defects, and we sure as heck aren't fixing their kyphosis. So all the dynamics that lead to the hernia are still there. And does it really make sense to think that you're going to slap a few sutures in and it's all going to be fine? Doesn't make sense to me, particularly when every other hernia in the body, mesh has been proven beneficial. It would be malpractice to fix most ventral and inguinal hernias today in the United States without putting mesh in. It's proven beneficial. So in my mind, mesh is a part of the answer. We just have to learn how to use it effectively and safely. So at this point, my concept is the bioresorbable meshes, I think, are proven to be safe. I'll show you some data on that. The major downsides are time and expense, but if we can reduce recurrences rates, I think those downsides are not a reason not to use mesh. If we're going to use mesh, these are the ideal characteristics. It's got to be safe, minimal risk for erosion, easy to use, position, fixate, effective, ultimately proven to reduce recurrent hernias, and that's something that we need to do yet. And it shouldn't preclude a safe reoperation because some of these patients, no matter how good we do it the first time, will have recurrences and need a reoperation. So those are our criteria for a good mesh, and I think the concept has to be a partnership. You can't expect the mesh to solve your tension problems. If you don't address tension as the first part of your operation, the mesh is not going to work. And it just pains me to hear surgeons say, well, the repair was kind of falling apart. I saw the tissue, the stitch is tearing out, so I put some mesh on. It's doomed. The mesh has no chance in that setting. I think the only way mesh works is if you really take all the tension you can off the repair, make the repair as good as you possibly can, then the mesh has a chance to provide some benefit. But the 2 previous randomized trials never addressed tension. They just put mesh on or didn't. And I think that accounts to some extent for the failure of benefit in those randomized trials. So here you can see that reconstructed hiatus I showed you earlier. Now we're putting the mesh in. This is the Phasix ST mesh. The coated side, the ST side, which prevents adhesions, is up. I mark it so I make sure I put it in the right way. You want the uncoated side down against the crura. And you can see how nicely this lays in. I put it in dry. As soon as it starts hydrating, it really shapes nicely to that bell shape of the hiatus. One of the challenges at the hiatus is it's not flat like the abdominal wall. It's a bell shape. And you need a mesh that really lays nicely, because if it doesn't lay against the hiatus, it's not going to incorporate. And if it doesn't incorporate, it's a waste of time putting it in. You can suture it. I like short absorbable tacks. Keep them up high on the left cruce. The aorta's down here. You don't want to tack low on the left cruce. You're pretty safe anywhere on the right side. Never tack up here. That's the pericardium and the heart. But if you know the landmarks, you know the anatomy. I've used thousands of tacks and never had a problem. I would never use a spring-loaded tacker or a long tack in this situation. It's too dangerous by these important structures. So as I alluded to before, we've put together a prospective follow-up starting in 2016 to look at the Phasix ST mesh as soon as it was launched, before it was even FDA approved at the hiatus. So 50 patients followed prospectively. We put together the initial results of this paper, and it's been published. Collis gastroplasty in 42%, diaphragm relaxing in 2 patients, 4%, both right-sided. Primary crural closure, Phasix ST mesh reinforcement, 1-year objective follow with the upper GI in all 50 patients, no mesh infections or erosions. Now bear in mind that the Phasix usually lasts about 18 months. So some of those patients, the Phasix should still be there. We're going to talk about longer data in 1 minute. Upper GI, 4 recurrent hernias, 4%, 8%. So that's objective follow-up, no reoperations. No recurrent hernias in patients with a Collis gastroplasty or a relaxing incision. We talked about that data a minute ago. Now with longer follow-up, 44 of the original 50 patients have longer objective follow-up. A couple have died, a couple have moved, and they were unreachable. So 44 of the original 50. Now the follow-up is 31.5 months. 5 recurrences, 11%. At over 2-year follow-up in all of these patients, and no mesh erosions or complications. And again, the mesh should be gone by 18 months. All these patients are greater than or equal to 2 years out. So that means all the mesh is gone. So I can say with real certainty that this mesh is safe to use at the hiatus. Whether it's beneficial needs to be proven in a randomized trial, and we're hopefully going to get that organized. But the data suggests a benefit to that combination approach of addressing tension and then using a safe mesh. Thanks. Sebastian, take it away.
Steve, thanks a lot. Very nice interpretive videos and slides. Very impressive. Thank you very much. I have 3 points. The first, I absolutely agree that we have not judged the effect of mesh implantation the right way, and that the randomized trials there exist do not show reality. I believe that. Otherwise, I would never think about implanting any more meshes, and I do. I do implant meshes, and I'm quite sure that there will be more mesh implantation in the future. I'm very sure. I also agree that a mesh alone might not be enough. I have no experience with this lateral incisions. I see patients for sure where I would think, okay, now we don't really have a lot of tissue, yeah. But I personally never do the lateral incisions, I have to say. And third one is I would absolutely partner and participate in a study really studying in a prospective randomized way the interesting data you just showed us. So we will be with you in a study like this, for very sure.
Well, thanks. Yeah, it's an important area, and we have to move forward with solid data. Retrospective analyses and so forth are great, but at the end of the day, we're going to need a study that shows that the combination of really good surgical technique, dealing with tension, with and without mesh, show the benefit of the mesh. But in my heart, I believe that since we're not dealing with all of these pre-existing conditions that we can affect, the collagen defects, the kyphosis, the weak tissues, the elderly patients, we just have to have something that makes that tissue stronger. I really believe that.
Let me get one question, Steve. When I just showed you data, and they are quite recent, that they really saw more than 60% of reherniations, of recurrences in the anterior area. So what I do sometimes is just one anterior stitch. The meshes you implant have a U shape. So how will we deal with those anterior herniations or recurrences? What's your thoughts about that?
Yeah, that's interesting. I think part of that issue, and like that picture I showed of that huge hiatus, in a lot of these patients, that frontoesophageal ligament is making up part of that anterior tissue. And I think there are surgeons that don't take that phrenosophigeal ligament out, and that tissue's crap. But when you leave that there and close the hiatus, it looks like the hiatus is nicely closed. But that phrenosophigeal ligament is crap. It's not going to stop a recurrence, and that's where that happens. If you cut that phrenosophigeal ligament tissue out all the way to the central tendon of the diaphragm, central tendon of the diaphragm is strong, strong tissue. That's not going to tear. So I like to cut all of that phrenosophigeal ligament tissue away right to the central tendon of the diaphragm. And I agree with you. Sometimes if you're going to make a speed bump of the esophagus, if you close the hiatus all the way posteriorly, because a lot of these elderly patients, the pericardium's hanging down, so you're going to make a big speed bump. Don't want that. And sometimes to get that hiatus together well, it makes sense to put an anterior stitch, but you can't put it through that phrenosophigeal ligament crap tissue. You have to cut that away and get your stitches into that central tendon of the diaphragm, and that won't come apart. So once you've reconstructed it anteriorly without that crap tissue, then you can reconstruct the hiatus posteriorly. And I don't think we're going to see those anterior recurrences, but I agree with you, it's an important issue.
I'd agree that this kind of kinking of the esophagus is a big, big topic. I think it's responsible for a lot of dysphagias directly after surgery, the early phase after surgery. And especially if you don't use like a Nissen or a Toupee, which avoids kinking much more than, for example, implanting a lynx. That makes a lot of patients having kinking. Yes, I agree.
Yeah, interesting.
Agree.
Well, great debate, great thoughts on, again, an unresolved issue. I'm just going to ask an audience poll question here. And so it's really just, if cost and availability of mesh were not an issue, how frequently would you use it in paraesophageal hernia repairs? If you think very frequently, then answer that you agree with Dr. DeMeester. If it would be very infrequently, say that you agree with Professor Schoppmann. And while you're doing that, I'm just going to ask a couple of questions that have come up and some of my own. One is for both of you: how snugly do you like to see the hiatus closed? Some people will close it around a bougie. Some people like to leave a little gap between an empty esophagus and a hiatus. Some people like to close it snugly against the esophagus. Tell me your approach to that part of it, because that may be part of our recurrence issue. Steve, go ahead.
Well, you saw my video. I close it snug around the esophagus. A couple points to that, though. In essentially all these patients, I've made a pneumothorax. I always make a pneumothorax in my paraesophageal hernias to get the diaphragms in neutral position. And if you don't make a pneumothorax, remember, when you deflate the abdomen, the hiatus is actually going to tighten a little bit. So with that caveat, I usually have made a pneumothorax. So when I'm tightening the hiatus, that's where it's going to stay when I deflate the pneumoperineum. But if you close it around a bougie, I challenge you to then take that bougie out and see how big that hiatus is. If you close it around a 60 French bougie, that hiatus will be way too big, in my opinion. You need to take the bougie out before you put your final sutures in to snug that hiatus up. And I don't think you need to leave room for a grasp or anything. If you snug it up just around the flaccid esophagus, so you take the tension off the esophagus and it just fills the hole, I think that's perfect.
Professor Schoppmann?
I agree. I'm a non-bougie man, so I never use bougie. I think it is very important what Steve said before. You shouldn't let yourself be irritated with the phrenicoesophageal membrane. It's very important to know where the diaphragm is and where this ligament is, because it has no tension. I close it quite close to the esophagus. I've seen that Steve does the fundoplication before closure of the hiatus. I think this is a very good strategy to avoid that you do a too tight closure, because if the fundoplication is not there while you close the hiatus, you have a compression of the esophagus, and you think that I think you regularly close the hiatus tighter. Yeah, that's mine. I think I'll do it looser than you, Steve.
Yeah, I'm pretty aggressive, because if the patients have some dysphagia, which is not super common, but if they do and you're worried it's the crural closure, it's easy to dilate it and open that crural closure up. So you can do that. You can't dilate a fundoplication, but a dilation will open a hiatus that's closed a little too tight.
I think you're application. I think it's not necessary.
Well, it never works. Yeah. But you can open the hiatus. If you don't believe me, close the hiatus super tight, put a bougie down, take the bougie out, take a look at your hiatus. You've opened it.
Right.
Yeah. Steve, I would agree with you on it. There are times when I wonder if that early on in the days of laparoscopy, people got concerned about dysphagia from too tight a hiatus. And I think for many years, we have been teaching to leave a gap because of fear of that postoperative dysphagia. And I wonder if that has confused some of our data about paraesophageal hernia recurrences, because if you don't correct that part of it, then it's harder to assess whether mesh makes a difference or not if you leave one thing undone.
100% for sure.
Yeah. And I agree with you, Steve. I close it snugly, and absolutely, you can dilate the hiatus. Sebastian, you've done a fair bit of work with links. Does that, because the links is only 7 millimeters in depth as opposed to 2 to 3 centimeters with a fundoplication, does that ever alter your thinking about the amount of length needed for the esophagus? I don't know if you do them in paraesophageal hernias, but does that ever alter your thinking in terms of what you're going to do as a reflux procedure in terms of needed length of esophagus?
Well, it did. I think it did with everybody, because when we all started with links, we all did minimal dissection, and we didn't mobilize the esophagus at all. So we just wrapped it around the part of the abdominal esophagus which was in the abdomen. Nowadays, I do a complete esophageal mobilization. I do the same mobilization as I would do with the Nissen fundoplication, and I would not try to. So I don't go for less intra-abdominal esophagus when I go for links. Concerning the paraesophageal hernias, I do links with the paraesophageal hernias. I think it might be of an advantage. The first one is, especially in patients where it is really hard to achieve a lot of intra-abdominal esophagus, they might be a compromise. Links might be a compromise. And the second one is, you all know this scar tissue development story. It really happens, and it is like a circumferential scar tissue development with the links, and this might help avoid some recurrences. I know we have data that recurrence rates are less after links. We know that, but principally, I think you should mobilize the esophagus with the same way you do it for a Nissen, but it might help you in the small number of patients where you have a problem getting the esophagus into the abdomen.
Thanks. So the poll question about how frequently would you use mesh frequently if cost and availability were not an issue? 2/3 said that they would use it very frequently. About 1/3 said you would use it infrequently. So with that in mind, Dr. DeMeester, what's important in the choice of a mesh when you think about using a mesh at the hiatus, and how do you gauge, because there are a number of different absorbable meshes available. What do you think about that?
Yeah, I kind of gave my list of ideal meshes. It's got to be easy to use and fixate, and I like a mesh that lays down over that bell-shaped hiatus, not one that's too stiff and constantly trying to flop up, because if you don't get it against the tissues, you'll never get tissue ingrowth, and the mesh is a waste of time. I think it needs to last a while. I think meshes that go away, 6 months to a year is too short. The longer the better. Obviously, permanent mesh is ideal, but the risk of erosion or a problem with permanent mesh, I think, makes it ill-advised to use it.
Have you ever
something that goes a long term? So I like the Phasix ST. It lays down nicely. It lasts for 18 months. Slow reabsorption, not impacted by infection or other issues. You can stitch right through it and put the toupee stitches right through the mesh and never have problems with it. So I think there are new meshes that are exciting, but we're looking for a mesh easy to use, positions well, gives us a good long time, 12 to 24 months, I would think would be a minimum for the mesh, and then low rate of complications.
So Steve, if you ever needed to use permanent mesh, it would be in a relaxing incision coverage. Professor Schoppmann, would you ever use permanent mesh at the height?
No, okay. We don't anymore. I agree. We have to talk about the time of resorption. I think I would stick with the same time, like 12 to maybe 24 months. Based on the data, we know that especially posterior recurrences occur within the first 1.5 years. I've used the Phasix. It seems to work very good.
Okay. Let me just see if there are other questions that people have asked. Dr. DeMeester, do you ever do a gastroplasty without doing the full extent of mobilization, or is gastroplasty always a last ditch maneuver after you've done complete mobilization, up to the pulmonary vein?
Yeah.
Question for you.
Yeah, my answer to that is I do the mobilization as best I can and as safely as I can. In some patients, it can be very difficult to see up there. If they have a huge hiatus and you can see great, no problem. But some patients, it's difficult to see high up in the mediastinum. Usually you can get well up towards the inferior pulmonary veins. But my concept is as soon as it gets difficult and you're beginning to get an issue or risk of injuring the vagus or the esophagus, I'd rather do a Collis and avoid an injury than persist with a difficult mediastinal dissection. And this discussion of these super high mediastinal mobilizations, I mean, that's really for the 1% of foregut surgeons. That's if you're doing it tranthoracically, no problem. We did that for years when we did transthoracic paraesophageal hernia repairs. If you're going to do that to get length esophagus, and that's why dividing the vagal trunks gives you 2 centimeters, 1 centimeter for one, 2 centimeters for both. The reason is because all the vagal branches to the pulmonary hilum tether the esophagus. At that point, the vagus is wrapped around the esophagus. It's sending branches to the pulmonary hilum. And if you don't divide all those vagal branches off the pulmonary hilum, which means the pulmonary artery, the bronchus, and the vein, you're really not doing much. So going up to that's typical. The vein, I don't do it. From laparoscopic, it's too difficult to divide all those safely. The risk of injuring a hilar structure to the lung, in my opinion, is not worth it. And so I will never do one of those extended mediastinal mobilizations from the abdomen. I would prefer to do a Collis. Okay.
Very good. Our time is drawing nigh. Another poll question, just to go back to the Collis issue. How often would you perform esophageal lengthening? If you're more on Dr. DeMeester's side, that this is something that you would do frequently, then poll in favor of Dr. DeMeester. If it's something that you would only do 1.5 to 2% of the time, or very rarely, poll with Professor Schoppmann. While we're getting those results in, just a quick note, I noted earlier on that Professor Schoppmann was the founder of the European Foregut Society. All 3 of us are active in the American Foregut Society. All of us have believed that it's been too long for us to have a specialty organization with collaboration between gastroenterologists and surgeons to really focus on foregut disease, just like the colorectal surgeons, the bariatric surgeons, and so forth have done. And we welcome international members as well, but go to foregut.org and check us out because we'd love to have your involvement. Those of you who showed up today clearly have an interest in this, and we want to provide a forum ongoing for discussion. So it looks like in the polls, about 2/3 are of the opinion that Collis should be done rarely, and about 38%, 36% is changing as we speak, are on the order of Professor DeMeester that it should be done frequently. Jen, I don't know how much time we have. It is at the hour, but if there are other questions, we can certainly forward them respectively to our colleagues here to get their answers.
I wanted to ask Sebastian one question on the links and paraesophageals. Do you do a motility test in your elderly paraesophageal hernia patients to decide if they can have a lynx? I mean, most of my patients are elderly, and if I do a motility test, they don't have great motility, and so I'd be reluctant or a little concerned about a lynx in them. Tell me your algorithm for that.
Well, that's a very good question. I mean, we didn't do links in paraesophageal patients before we didn't have the data and our own experience concerning the outcome of links in IEM patients. So today we know that it doesn't really matter, or motility doesn't have that big impact on the function and side effects from links. So therefore, in most patients, functional testing, in most patients with paraesophageal hernia, functional testing can be difficult, can harm them. So in real big ones, we don't do it. And I'm not afraid implanting a lynx anymore. So we did quite a handful, 2-3 handfuls of patients who had real severe motility disorders with links, and it was no problem. So therefore, it's in the daily practice is no more an issue.
Interesting. Okay.
Okay. Well, very good. This will end our very thoughtful input from both Professor Schoppmann and Dr. DeMeester. As always, leaders in the field. And I'd like to thank both of you and for all of the attendees to take time out of your day or night, whatever time it is, frame wherever you are, to be part of this. So with that, we will sign off.
Thanks, Reg, for great moderation. Sebastian, thank you. Great concepts. A lot of fun.
Steve, it was an honor. Thank you very much.
Thank you, guys. Have a good day.
Bye.
Okay. Okay. Bye-bye.